Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 574 of our pharmacotherapy series, which majors in geriatric drug use. The first case involves patient TMC from part 573 of this pharmacotherapy series. And the first question reads: is the combination of furosemide and hydrochlorothiazide the most appropriate diuretic regimen for TMC? Loop diuretics are generally more effective than thiazides in providing symptomatic relief. Furosemide is also preferred in TMC because hydrochlorothiazide is less effective in moderate to severe renal compromise, that is, a creatinine clearance less than 30 ml per minute. Furthermore, the combination of furosemide and hydrochlorothiazide is duplicative in diuretic action and may be excessive. Discontinuing the hydrochlorothiazide will likely help with TMC's hyperkalemia and slightly dehydrated state. Regular monitoring of serum creatinine, urea nitrogen, sodium, and potassium is essential while on diuretics. The need for potassium supplementation will depend on the resultant level after TMC adheres to furosemide while being maintained on an angiotensin-converting enzyme inhibitor. Elderly patients often dislike taking diuretics because of the frequent need to urinate. TMC may be advised to take furosemide later during the day after she returns from her social engagements. TMC has been taking captopril 25 mg 3 times a day. My next question to you reads: is this an appropriate choice of angiotensin-converting enzyme inhibitor for TMC? Blockade of the renin-angiotensin-aldosterone system is essential in the management of heart failure. However, 3 times daily dosing of captopril is inconvenient and may contribute to poor adherence. Although captopril, enalapril, and lisinopril have all proven efficacious for heart failure in clinical trials, lisinopril is the only agent of these that may be dosed daily. Alternatively, fosinopril may also be desirable based on its 50% hepatic and 50% renal elimination profile. An angiotensin II receptor blocker may also be appropriate if therapy with an angiotensin-converting enzyme inhibitor is not tolerated. Although previous studies have supported the addition of an angiotensin II receptor blocker to angiotensin-converting enzyme inhibitor therapy based on a lower mortality and hospitalization rate compared with an angiotensin-converting enzyme inhibitor alone, more recent data present concerns about the use of combination therapy, particularly in the elderly, owing to higher risk of hyperkalemia and worsening renal function. TMC is being treated with atenolol 50 mg daily. The next question reads, is this an appropriate choice of beta blocker for TMC? The beta blockers carvedilol, metoprolol, and bisoprolol have been proven to reduce morbidity and mortality in patients with heart failure. In TMC's case, atenolol is not clinically indicated for heart failure and should be discontinued. Additionally, it is renally cleared and may contribute to excessive sluggishness in an elderly patient with compromised kidney function. Although any of the proven agents would be appropriate, extended-release versions of carvedilol or metoprolol may reduce TMC's medication burden. TMC does not take her niacin because she experienced unbearable facial flushing. Despite her history of myocardial infarction, she does not believe that cholesterol and heart disease are major health concerns for a woman. Are women older than age 65 at different risk of death owing to coronary heart disease, abbreviated as CHD, compared with their male counterparts, and is it important to manage cholesterol in an elderly woman with coronary heart disease? More than 60% of cardiovascular disease, abbreviated as CVD, deaths occur in people aged 75 or older. Approximately 70% of older adults aged 60 to 79 have cardiovascular disease. For those over age 80, 83.0% of men and 87.1% of women have cardiovascular disease. Although male sex is an independent risk factor for cardiovascular disease, more women than men die from heart attacks because these events occur in women at an older age. The significantly higher rate of hypercholesterolemia in women seems also to predict a higher cardiovascular disease risk than for men later in life. Therefore, it is important to treat dyslipidemia in most patients with clinical atherosclerotic cardiovascular disease, in those aged 40 to 75 with diabetes mellitus who have LDL cholesterol levels of 70 to 189 mg per deciliter, and in those without diabetes mellitus and an estimated 10-year atherosclerotic cardiovascular disease risk equal to or greater than 7.5%. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 575.